Yeah, Pooja, you can start, I think.
Good evening, everyone. A warm welcome to all the postgraduate students, esteemed faculty members, and the respected dignitaries who have joined us today for the ISA National PG online class. To begin this session, on an auspicious note, we seek the blessings of Saraswati Devi. So we will play the Saraswati Vandana now. So now let's begin today's session. Myself, Dr. Pooja. I'm doing DM Cardiac Anesthesia in AIMS Rishikesh, and I have the honor of being your screen coordinator for today's session. It is indeed a privilege to welcome you all to the enriching academic discussion. To formally commence the session, I now invite Honorable Secretary Dr. Sukhminder Jeet Singh Bajwa sir to share a few words with us.
Thank you, Dr. Pooja. As a tradition, the classes I used to do on Monday, but I think because nowadays with the conference season going on, the faculty, the coordinators, the secretary himself, we were traveling, so we did it on Tuesday. And what an apt topic, foreign body in trachea and of foreign body in a bronchus. I think it looks very simple sometimes. And when we were also doing the post graduation, we were very enthusiastic about dealing with such cases because invariably our senior used to tell that they used to do the laryngoscopy and they didn't allow the ENT surgeon or the other person to come, and they used to remove it themselves, and they used to feel, cloud seven after removing the foreign body. But I think that little knowledge is a dangerous thing. Many times, what happens when you are attempting to do these things without proper appropriate technique or inadequate anesthesia, the movements of the tracheal muscles, you are pushing into the body into the bronchus that can lead to catastrophe. Moreover, I think even you are removing it without securing the airway, so that's another thing. And not just securing, rather sharing the airway also with the people who are going to be on the surgical side. And then another challenges come from the type of the foreign body. Where it's a hygroscopic foreign body, it's going to swell with the time, or it's going to be a very, sometime with the spikes on it, which makes it entrapped in the trachea. So there are so many challenges with the different and varied structure or morphology of the foreign body. And it variably these patients are the young children, accidental ingestion, and that leading to the impactness of that foreign body into the trachea. So, and very difficult part. On one side, you are giving pediatric anesthesia. Second time, you are sharing the airway, the type of body. So, how much time you give to the surgeon to extract it. So many things are there. I think it's a very challenging. And with the current scenario, with the medical legal implications are there also. It's a very, very difficult scenario for an anesthesiologist because the foreign body is a procedure which you can retract. the surgeon or the other person whosoever will be there just have to just extract the foreign body. But the management of such patients during that particular period is the most challenging, I think. Today we will be, I think, touching those challenges with a varied presentation with the different scenarios also. And we have none other than Dr. Madhavi, madam, with her team here, well prepared, and Dr. Chandrakala and Dr. Bhagya. They will be having the fellows and the people who are doing the pediatric anesthesia. So I think we have got a very good team today. It will be a very, very enjoyable class. So Soma, we can start with the proceedings from here.
Thank you, sir.
Pooja. Yeah.
Thank you so much, sir. Now, I would like to welcome my co-screen coordinator, Dr. Rajni Yadav, to take over and kindly come in the session.
Thank you, Dr. Pooja. Myself, Dr. Rajni Yadav, Assistant Professor at the Department of Anesthesia in Sarojini Naidu Medical College, Agra. Before starting the session, I would like to introduce our esteemed faculties. So our faculty is Dr. Madhvi ma'am, who is a professor and HOD Department of Pediatric Anesthesia, Indira Gandhi Institute of Child Health, Bangalore. She has done her MBBS and MD in 2001 and senior resident in AIMS and New Delhi, as well as senior resident in Lady Harding, New Delhi, working as teaching faculty in Indira Gandhi Institute of Child Health from 18 years. She has various studies published in pediatric anesthesia in various index journals, both national and international. She is a fellowship coordinator for Rajiv Gandhi University Health Sciences Accredited Pediatric Anesthesia Fellowship Program, and she also started a new fellowship course, Pediatric Regional Anesthesia, from 2025. She is a Secretary, Indian Association of Pediatric Anesthesia and Karnataka branch in 2023, and she is a member of Institute Ethical Committee, certified as trainer for Asian Society of Pediatric Anesthesia. She has been an examiner for various pediatric anesthesia fellowship exam, and she has attended several conferences as faculty speaker, conducted various workshops, CMEs on pediatric anesthesia. She has an area of interest in pediatric airway, simulation, neonatal anesthesia. Other interests are wildlife photography, music, and government cooking. Our next faculty is Dr.
Rajni.
Chandrakala ma'am.
Dr. Rajni, excuse me, the slides are not seen. The CV PPT
Yes,
is
ma'am.
not seen. Can you please show the CV PPT of Dr. Madhvi ma'am?
Not seen,
Share,
ma'am.
No, it was
share
not
the
seen.
slides. Share the slides.
Share the slides, please.
Oh, okay, ma'am. Sorry.
Anyway, if you keep on speaking about Dr. Madhavi, the evening will not end. I'm telling you. Evening will end rather, madam. That will not end.
Just make it wide, yeah.
Yeah, is it visible, ma'am?
Yes, it is visible.
Thank you.
It is visible.
Just let it be there for 30 seconds.
Yeah.
Anybody can read madam's achievement. We don't have to repeat again. It's very well written there. The best part is the wildlife photography and the gourmet cooking. So we will be guests to madam at some time.
Yes,
Okay,
you're all most welcome.
Our next faculty is Dr. K.R. Chandrakala ma'am, who is a professor in anesthesia in Indira Gandhi Institute of Child Health. She has a PG teaching experience of 15 years, and she has a special interest in pediatric airway achievements, and she has 2 international publications and 10 others. And our next faculty member is Bhagyashree ma'am, Bhagya Devi ma'am, who is assistant professor in the Department of Pediatric, Indira Gandhi Institute of Child Health, Bangalore. She is a fellowship in pediatric anesthesia, postgraduate certificate in child and adolescent mental health, and PG teaching experience of 12 years. And she also has a special interest in pediatric anesthesia. Before handing over the session to the faculty members, I would like to quickly inform the rules of the class. And this includes audience will all be muted for the duration of the talk, and they can type their queries in the chat box, and audience to keep their videos off. Now I would like to hand over this session to the Madhvi ma'am to please introduce their presenters.
Good evening, everybody. At the outset, I would like to thank Dr. Bajwa and Dr. Madhuri Kodi for giving us this great opportunity to share our experience with everyone. And the topic given to us is foreign body bronchus. As already Dr. Bajwa has said, it's a very important and challenging aspect of pediatric anesthesia, and unfortunately it is also a very common scenario in our practice, which we see almost earlier we used to see 2 or 3 foreign body bronchus per week in our emergencies. Thankfully, be due to awareness, or I don't know, maybe because the children are going to other centers nearby to their places where they live, we don't get that many cases nowadays. We have also over many years developed newer techniques, and the surgeons are also developing their techniques better because of the rich experience which we have had from so many years. And without further wasting any more time, I would like to introduce our first speaker. Our first speaker is Dr. Lakshmi Prabha. She is doing fellowship in regional anesthesia, pediatric regional anesthesia with us, and she will start with an introduction of this topic of foreign body, how it presents, and how to work up a case of foreign body when it first presents to us. Over to Dr. Lakshmi Prabha.
Thank you, ma'am. A very good evening, everyone. Myself, Dr. Lakshmi Prabha. I'll be taking you all through a short journey, as in how, what, and what happens when a child accidentally aspirates a foreign body. What is foreign body aspiration, first of all? Foreign body aspiration is an accidental lodgement of a exogenous organic or an inorganic object in a laryngotracheobronchial airway, which can lead to complete or partial airway obstruction and its complications. The incidence of foreign body aspiration is 109.6 per 1 lakh. According to a study conducted in 2023, the global burden of foreign body aspiration among under 5 children. And can anybody put up in the chat box, what is the most common age group for foreign body aspiration to occur? I hope most of you would have answered 1 to 3 years of age. The reason for them being more vulnerable is that their natural tendency to orally explore whatever objects around them, and also their natural tendency to play and cry while eating, the loss of molar tooth to grind and break them into fragments, the presence of immature glottic reflex, the lack of coordination between the tongue and mouth while swallowing, and last but not the least, the lack of parental supervision. What are the sites of a foreign body that can be presenting is, they can be presenting in larynx or in the trachea or in the bronchus or in the smaller airways. Can anybody put up in the chat box, what is the most common site for a foreign body to be lodged? I hope most of you would have answered as the right main bronchus. 80 to 90% of the patients present with a foreign body in the right main bronchus and the right lower lobe. The reason for it being, right main bronchus is a larger diameter, because of which it has the increased airflow, and so that the foreign body tends to go towards the right side. And the angle of divergence from the tracheal axis is smaller, making it more in line with the trachea. And the carina is slightly to the left of the midline, making it more in line with the trachea. And what are the types of foreign bodies that can be present? They can be broadly classified into organic and inorganic can be classified into metallic and others. So the PMET is the most common foreign body that is being documented according to the Foreign Body Aspiration in Children published in International Journal of Contemporary Pediatrics in 2019. The other organic foreign bodies are beans, watermelon seeds, sitafal seeds, animal shells, popcorn, and grapes. And the metallic foreign bodies are coins, nails, screws, hairpins, and safety pins. Among the metallic foreign bodies comes the lithium batteries. Their uniqueness is that they cause electrolysis and leads to coagulative necrosis, which can lead to fistula formations in the airway. So it is very important to remove the batteries as early as possible to prevent further damage. The other foreign bodies are pebbles, rocks, and woods and toys. Now that we have seen how it gets aspirated, where they can go and lodge, we'll see what they do once they find their place in the airways. So if it is an organic foreign body, they tend to absorb water and they swell rapidly. And also because of the oily secretions coming out of the foreign body, they cause an inflammatory reaction leading to mucosal edema, which leads to a conversion of an incomplete obstruction into a complete obstruction. And over a period of time, they can also break and migrate distally and cause obstruction of the distal airways. When it comes to an inorganic foreign body, as in pins or screws or safety pins, because of their nature to be sharp, they can cause trauma to the airways, which can later lead to ulceration, erosions, and fistulas, stricture formation, and granulation tissue formation. So moving on to the history and phases of presentation, in children, witnessed choking event is highly suggestive of an acute aspiration. In case of a chronic foreign body aspiration, there is a higher tendency to have a misdiagnosis of URTI, asthma, or pneumonia. What are the three phases the child can present with? Are phase 1, which is an acute phase, which can present with choking immediately after aspiration, leading to violent cough, stridor, respiratory distress, wheeze, and slowly over a period of time, the receptors get adapted, leading to phase 2. In phase 2, it is the asymptomatic phase where the foreign body aspiration is either forgotten or neglected, the reflexes become relaxed, and there is cessation of symptoms. So it takes a few hours to weeks for the child to present to us. In case of phase 3, it moves on to the stage of complications where we neglect the foreign body and it has been there for a long period of time, leading to secondary effects of airway obstruction like an erosion, like causing pneumonia, abscess, and atelectasis. So only 57% of children present with classical triad of clinical features like unilateral wheeze, paroxysmal cough, unilateral decreased breath sounds. And the clinical features also depends upon the location of the foreign body, size of the foreign body, nature of the foreign body, and time since inhalation. 50% of diagnosis happens in first 24 hours, but 80% happens within the first week, and some might take even years to present. Can any of you guess if a child comes with sudden total or near total obstruction with cough, hoarseness, aphonia, choking, and dyspnea, and if it is a total obstruction coming with asphyxia, cyanosis, and death, what diagnosis would it be? It is a laryngeal foreign body. In the laryngeal foreign body, if it is completely obstructing, majority of the child will present with asphyxia, cyanosis, and it might even lead to death. The diagnosis of it can be done using a lateral and AP view X-rays of the neck, but direct laryngoscopy confirms the diagnosis and provide access for its removal as well. Moving on to tracheal foreign bodies, similar to laryngeal foreign body, they present similarly but without hoarseness or aphonia. They can even present with hemoptysis if it is a sharp foreign body. And in case of a tracheal foreign body, we can make out audible slap and palpatory thud. It is because of the foreign body which is moving during inspiration, and during expiration, it comes back again and hits on the vocal cord, giving a unique sound. And children with tracheal foreign body also have wheeze, which mimics a asthmatic wheeze. For diagnosis of a tracheal foreign body, we have to take a lateral and an AP view X-ray of the neck. In case of a coin in the trachea, in the lateral view X-rays, if the coin is in the sagittal plane, it is in the larynx, and if it's in the coronal plane, it is in the esophagus. And in the esophagus, we can make out the coin using the double rim sign. And the definitive diagnosis is always using a bronchoscopy. Moving on to bronchial foreign bodies, they always present mostly with classical clinical triad of clinical features, which is paroxysmal wheeze, paroxysmal cough, unilateral wheeze, and unilateral diminished breath sounds. They present in different phases based on how much obstruction is there. Initially, they can present as with cough, blood streak sputum. If it is a non-obstructive foreign body, they can be asymptomatic. If it is near total obstruction, the kid can present with signs of asphyxia. If it's slight obstruction, they can present with wheeze. If it is a greater obstruction, emphysema and atelectasis might be present. In case of persistent chronic foreign body, bronchopulmonary disease will set in. Why does bronchial foreign bodies can present in different phases? What is the mechanism behind it? They follow a valve mechanism, which again consists of three different mechanisms. It is a bypass valve mechanism, check valve mechanism, and a stop valve mechanism. Bypass valve mechanism is a two-way mechanism in which the foreign body is not completely obstructing the airway. So during inspiration and expiration, there is ingress and egress of air happening, because of which there is no collapse or no emphysema. Whereas in check valve or the one-way mechanism, during inspiration, as there is enlargement of the bronchus, there is ingress of air happening. But during expiration, the foreign body embedded in the swollen mucosa prevents the exit of air, leading to air trapping. And over a period of time, it can lead to obstructive emphysema. In stop valve or no-way mechanism, the foreign body completely obstructs the airway. There is no ingress or egress of the air inside the airway, leading to absorption of air and results in collapse of the lung. Moving on to diagnosis, history and examination plays a very important role, as we have discussed the different phases of presentation and the different history the kid can be presenting with. To be specific with the respiratory system examination, the kid can present with features of airway obstruction like nasal flaring, tachypnea, intercostal retraction, suprasternal retractions, unilateral wheeze, impaired percussion note, limited chest expansion, and diminished breath sounds and decreased vocal fremitus. Monitoring oxygen saturation by pulse oximeter will also help to know the progression of the disease. And chest X-ray helps in diagnosis, as I've told earlier. But the definitive and gold standard is always a rigid bronchoscopy. Moving on to chest X-rays. Chest X-rays help us in identifying a radio-opaque foreign body, the position of a radio-opaque foreign body. But unfortunately, only less than 20% of aspirated foreign bodies are radio-opaque. So what do we do when we have an organic material which is radiolucent? Then how do we diagnose them? In case of radiolucent foreign bodies, then we can make out by indirect signs of airway obstruction, like hyperinflation caused by obstruction of the distal airways, leading to air trapping and obstructive emphysema. And if the obstruction is complete, it can lead to atelectasis of the affected airway. There will be mediastinal shift if it is hyperinflation towards the opposite side, and if it is atelectasis, mediastinal shift will be towards the same side. In case of an inspiratory chest X-ray, we can make out unilateral hyperinflation, lobar or segmental atelectasis, mediastinal shift, or pneumomediastinum. But expiratory chest X-rays are more sensitive for helping us find the air trapping and obstructive emphysema. So these are the different X-rays with different foreign bodies in the airway. The first X-ray shows a hairpin in the right bronchus, and the second one shows a safety pin in the bronchus in the AP and lateral view. Third one shows a earring in the bronchus in the AP and lateral view. And the fourth one shows a screw in the left bronchus. And the first X-ray shows right hyperinflation, which has happened probably because of a partial obstruction leading to allowing only ingress of air, and there is no egress of air happening, because of which there is air trapping and obstructive emphysema. The second picture shows atelectasis, which would probably be because of a complete obstruction of the airway caused by the foreign body. This is the inspiratory film on the left and the expiratory film on the right. This is taken to make out the air trapping, which is very clearly seen in expiratory film only. So you can see in the inspiratory film, there is air inside the lungs in the left side. But in the expiratory film, you can make out which should have actually decreased because of the egress of air has not decreased. There is air trapping happening, and in the expiratory film, it's very well made out. So many chest X-rays may have completely negative findings also, especially within the first 24 hours following aspiration. A positive history plus clinical symptoms of aspiration may be sufficient to justify a bronchoscopy. Moving on to complications of foreign body, it can lead to obstructive emphysema, atelectasis, bronchiectasis, hemoptysis, lung abscess, pneumothorax, and pneumomediastinum. What do we do when there is a child choking and it's an emergency? The emergency treatment for aspirated foreign bodies, according to advanced pediatric life support, once there is a choking child, you should assess the child whether there is an effective cough and crying or not. If the child is crying and there is an effective cough, then you should encourage coughing and support and assess continuously for danger signs. But if there is no effective cough, then assess for consciousness. If consciousness is not there, then we should immediately start CPR. But if consciousness is there, then we have to give 5 back blows and 5 chest thrusts, and we have to assess and repeat. So in case of an infant back blows are given by rescuer holding the infant in a head down position, sandwiched between the sandwiching the infant between one hand, supporting the neck, and the other hand delivering the back blows. In case of chest thrust, the rescuer holds the infant on thigh in head down position and delivers up to 4 chest thrusts, just like chest compressions. Heimlich's maneuver is performed for a child more than 1 year of age in erect sitting or standing position, encircling from behind and fist in epigastrium between the xiphoid and umbilicus, and apply abdominal thrust. So I'll be ending my talk with a brief case history so that Dr. Akshara will take you on the intraoperative and perioperative management of the same. To start with the history, 1 year, 5-month-old female child weighing 10 kgs presented with complaints of paroxysmal cough since an episode of choking while eating peanuts. The complaints of noisy breathing and audible wheeze for 1 week, breathlessness on exertion, low-grade fever for 3 days, poor response to salbutamol nebulization given by the local practitioner. There is no history of any allergy or asthma or URTI. And on examination, vitals, mild tachycardia, tachypnea was seen, BP was normal, mild low-grade fever was seen, saturation was 94% on room air and 98% with 2 liters O2. General examination, the kid was alert, a bit mild restlessness and sick looking. Airway was normal, there was no stridor, and oropharynx was clear. Respiratory system examination, on inspection, chest movements were equal bilaterally, trachea was central. On percussion, mild increased resonance was present over the right hemithorax. On auscultation, decreased breath sounds on the right side with wheeze present, and left lung was clear. Cardiovascular system, abdomen, and central nervous system were unremarkable. On investigating, the CBC showed mild neutrophilic leukocytosis, and chest radiograph PA view showed cardiomediastinal cell out normal, right lung hyperinflated with depressed left hemidiaphragm, probably denoting air trapping, no visible radio-opaque foreign body seen, and there was no pneumothorax. This is a case of foreign body, most probably in the right main bronchus, causing partial obstruction of the airways. These are the various foreign bodies which we have received in Indira Gandhi Institute of Child Death over years. So as we've completed our journey, let's see how much all of you have captured along the way. It's time for a quick recall. I'll be asking few MCQs and I'll be giving some 20 to 30 seconds time for you all to put up your answers in the chat box. Then I'll be displaying the answers. Moving on to the first question. The classical clinical triad of bronchial foreign body is option A, cough, stridor, and hoarseness. B, cough, unilateral wheeze and diminished breath sounds. C, cough, cyanosis and drooling. D, hemoptysis, aphonia, and chest pain.
Many have answered option B.
Yes, option B is the correct answer, which is the classical clinical triad of a bronchial foreign body. So we'll move on to second question. A child presents with audible slap and palpable thud on examination after suspected aspiration. These findings are more specific for A, laryngeal foreign body, B, tracheal foreign body, C, bronchial foreign body, and D, esophageal foreign body.
We have received multiple answers, both option A and Dr. Neil has put option C.
Okay, so
Give
both
them
of them
some
are
more
wrong.
time. Give them some more time, Dr. Pooja.
Yes, ma'am. Yes, ma'am.
Okay.
Now the audience are encouraged to answer right or wrong. You remember it throughout your life if you usually give the right or wrong answer.
Yeah.
Majority has answered B option, ma'am. A also,
Yes.
many have opted.
Okay, so B is the correct answer because this audible slap and palpable thud are produced classically because of the movement of a foreign body in the trachea. During inspiration, they just go down, and during expiration, they come up and hit the vocal cords. That's when this is classically heard. So this is mainly present and seen only in case of a tracheal foreign body. So moving on to the third question, in a check valve mechanism of airway obstruction due to foreign body, air enters and exits freely. There's no emphysema, option A. Or option B, air enters but cannot exit, leading to hyperinflation. C, both ingress and egress are blocked, causing collapse. D, neither inspiration nor expiration is affected.
Many of them are answering B.
Sorry, ma'am, is it B or D?
B.
Okay.
B for
So that is the right answer. Check valve mechanism is nothing but one-way valve sort of. So it just allows entry of the air but doesn't allow exit of the air. So it leads to hyperinflation and leads to air trapping and obstructive emphysema sort of features. So moving on to the fourth question, which of the following chest X-ray view is more sensitive for detecting air trapping in foreign body aspiration?
Everyone has answered B.
Yes, expiratory chest X-ray have a unique tendency to show obstructive features, so they can catch the air trapping happening during expiration. So thank you, everyone. My take-home message is that we should always do a final chest X-ray immediately before bronchoscopy, because all the foreign bodies most of the time have the tendency to shift position, so they might be in a different place than what we were expecting for. So thank you, everyone, for this opportunity.
Ma'am, actually, we had two queries in the chat box. One was
Okay.
from Dr. Rajiv. So, sir has
Yes,
asked, can there be chance of negative pressure pulmonary edema as a complication in case of complete obstruction of airway?
It can be there only in case of a foreign body which is in the trachea and which is causing a complete obstruction of the airway. But in case of a foreign body in a bronchus, right main or left main bronchus, or in the lower airways, it doesn't happen. So it is like an acute emergency where the foreign body is in the trachea and it is as big, it is obstructing completely the trachea, then yeah, it can happen.
Okay, I think it's clear now. One more query was there. Which laryngoscopy is better? That is BD or direct conventional laryngoscopy? And if in case of a difficult airway, what can be done?
Okay, so direct laryngoscopy is better because it allows you to see as well, and it also allows you to remove off the foreign body if it's a laryngeal foreign body directly. And if it's not a laryngeal foreign body, then always rigid bronchoscopy is the gold standard. Laryngoscopy will not help. So we should go for bronchoscopy and try to remove it off. And I'm sorry, what was the second half?
Ma'am, if it was a difficult airway, what should we do?
Okay, so the intraoperative management will be dealt in detail by Dr. Akshara in the next this thing. She'll be covering everything. So
Okay, thank you, ma'am. Thank you so much.
yeah, thank you.
There is one more query is there. What is the role of
Yes.
CT scan in foreign body bronchus? Role of CT
Okay.
scan.
CT scan is like an advanced imaging. So in chest X-ray, we can just grossly make out the issues which is going on. But in case of a CT scan, you can make out where exactly, even in the smaller airways, if there is obstruction, you can make out where is the obstruction. And also the complications following that, like atelectasis, or if it is obstructive emphysema, or any lung abscess which has turned because of a chronic foreign body, whatever is the complications can be very well made out in a CT scan. So in case of emergency, we don't get it done. But if we have enough time and we want to know, and if it's a very much chronic foreign body which could have led to multiple complications, then we can get a CT scan done to find out what is the problem happening because of the foreign body for a chronic time present there.
Thank you.
Can
Thank
I
you.
add one answer to the difficult airway question? Can you hear me?
Yes, ma'am.
So difficult airway and foreign body bronchus is a very bad combination, but you have to follow all the difficult airway algorithms for that, and you have to keep a tracheostomy ready. The surgeon has to be prepared to go in immediately because we may not have much time to do. I mean, while trying for the difficult airway to secure the airway in a difficult airway, we may lose a lot of precious time, especially because we are also dealing with an obstructed airway on top of that. So whatever it is, apart from all the things that you do, anyway, you do keep tracheostomy ready for difficult airway, but in this case, you should not hesitate to go in for a tracheostomy.
Okay, thank you, ma'am.
Madhvi ma'am, please introduce our next presenter.
Yeah. Our next presenter is Dr. Akshara. She is also a fellow in pediatric anesthesia in our department. Dr. Akshara will now take you. Now we have already received the case which Dr. Prabha has told us about, and now the time is to wheel the child into the OR, and Dr. Akshara will tell you how we prepare ourselves in the OR and then how we proceed with the anesthesia for the rigid bronchoscopy of this case. Over to Dr. Akshara.
Thank you, ma'am. Good evening, everyone. So I'll be continuing with the case that Dr. Lakshmi Prabha has presented. So this is a child with no comorbidities, 1 year, 5 months, weighing 10 kg, and positive findings are the audible wheeze with the paroxysmal cough, the classical triad, with low-grade fever. And there is tachypnea, tachycardia, mild fever, and requiring oxygen to maintain 98%. And it is slightly sick-looking child, but there is no stridor. So Q&A to the audience. For this child, can we wait for 6 hours for NPO for solids, or do we need to take the child immediately? So as the child is not in distress, and we can wait for 6 hours. So surgical plan will be rigid bronchoscopy with foreign body retrieval, and our anesthetic plan will be general anesthesia with controlled ventilation. So this is a stable child with slightly delayed presentation, and on X-ray we can assume that it is lodged beyond the carina. And in children where emergency is required, where we don't need to wait for NPO, if the child is in severe distress, or if it's a tracheal foreign body causing complete obstruction, or any sharp objects. So the concerns of anesthesia are we're sharing the airway with the surgeon. There is a risk of hypoxia in such cases where it can lead to intraoperative cardiac events. Risk of displacement of the foreign body either up or below the airway. Risk of airway trauma, and risk of perioperative respiratory adverse events where laryngoscopy, laryngospasm, bronchospasm, persistent coughing, and rapid desaturation can occur. So what are our goals? So you have to maintain adequate ventilation and oxygenation, maintain adequate depth, prevention of pulmonary aspiration, quick recovery, and minimization of secretions. 1 second. So by preoperative preparation for this child, we can wait for 6 hours of NPO, take the high-risk consent, arrange a ventilator and PICU bed, be nebulized with Burocort preoperatively. Injection hydrocortisone 4 to 5 mg per kg IV can be given. When the child is coming from the ER, you make sure that the child is on oxygen while during transport, so it doesn't land up in desaturation as soon as you receive. And keep all the standard ASA monitors ready, and keep the OT at temperature of 27 degrees. So should a sedating pre-medication such as oral midazolam should be given to reduce anxiety, true or false? So sedatives are better avoided because the child is having its respiratory rev that's maintaining its saturation. We don't want to cut that off. And any child that is not NPO or NPO, we give IV ondansetron 0.15 mg per kg. If the child is not NPO in a full stomach, we will put a suction catheter and suction the stomach before induction. So the equipment that we need to prepare in the OT are adequate size laryngoscopes, in this case, curved blade MAC 1, adequate size of ET tube, and one size smaller, so around 3.5 and 4 cuffed and uncuffed. Airway, oral and nasopharyngeal, nasal prongs, a catheter mount, cricothyroidotomy set, a tracheostomy tube, in this case maybe a 4-size tube, suction catheters, and properly sized supraglottic airways. And drugs, propofol, ketamine, fentanyl, specific to this case, LOX 4%, the normal resuscitation drugs, and if needed, if it's in the plan, dexmedetomidine. So as you can see, we have, this is the catheter mount. This will help us connecting the closed circuit to the ventilating bronchoscope. This is the tracheostomy tube, oral airways. This is our emergency cricothyroidectomy set that we have in each OT. We have connected to 20 gauge cannula to a 2 cc syringe, and then a ET tube connector. Adequately sized ET tubes, scope, and this is blockbuster LMA and Ambu LMA and nasal cannula. So we should also be prepared, and the surgeon should also be prepared. It's not like we induce and then they start getting their equipment ready. These are the various bronchoscopes that are available in our institute. These two are neonatal scopes. These are only for diagnostic purpose, and you cannot remove any foreign body through these two. These are just 20 centimeters in length. And this is the workhorse. This is a 3.5 size internal diameter. And they're color coded also, yellow, red. This is 4 and this is 6. This is the catheter mount, and this is their forceps, which they will be putting through the scope. So these are the sizes of rigid bronchoscope available. We have stars. So according to the age group, you can notice that the internal diameter and outer diameter are different. So the outer diameter is what will be touching the larynx. So you have to make sure that this is not too large for the child. Invariably, for a small child less than 1 year, it ends up being slightly larger, like around 5.7 mm. So we can expect trauma, airway edema in almost all these cases. So the size ID and OD will be written as seen here. So just a second. So this is a this is the adapter that they connect to the ventilating bronchoscope. So through this, they will put the fiber optic. Through this, they will put the telescope. So when the telescope is inside, this gives no influx of air. So you'll be able to ventilate well. Suppose the telescope is not there, they move this slot to the glass. So that time you'll be able to ventilate. Suppose you're having desaturation episode, you should ask the surgeon, communicate to them, and they'll close this slot. If it's open to this slot where they're trying to suction, then there'll be a lot of air leak. Yeah, this way. So these are the two types of forceps that they'll able to hold the foreign body. This is optical forceps with an alligator jaw. This is usually for inorganic foreign bodies, and this is optical forceps for organic matter. And this is the telescope through which the light source and the prism is inserted. This is their setup. Make sure the light source, white balance, all of it is done before you take the child inside and start to induce. So we do not give any atropine or glycopyrrolate in our institute. We straight away take the child, pre-oxygenate with the mask, and if the IV line is not present, we do inhalation induction with sevoflurane. And if IV is present, we start off with fentanyl 2 microgram per kg with ketamine 2 mg per kg. And if the child is not NPO, we will do a modified RSI. I'll just play a video. This is a video of a different child, but this is the same protocol that we follow for all our children. All the standard ASA monitors are connected. Propofol 2 mg per kg is given. Check ventilation is done with a closed circuit with a nasal cannula from the aux already connected. So this is the surgeon already prepared with sterile gloves. So after that, ensure that adequate depth is there. We'll do a check laryngoscopy. Visualize that the oral cavity and larynx, there is no foreign body, and spray the cords with lignocaine up to 4 mg per kg for topical anesthesia. So if there is no suspicion of tracheal foreign body, IV atracurium 0.5 mg per kg is given. Alternatively, you can give scoline 2 mg per kg. the surgeon will do the direct laryngoscopy and intubate with the bronchoscope. So we connect the closed circuit to the catheter mount and catheter mount to this side port. You can also use a JR circuit if preferred in your institute. After this is connected, you need to check whether they have intubated correctly. You have to check the 5-point auscultation and look for the EtCO2 trace. As you can see, they have already closed this slot, so you will get a good EtCO2 trace. So Q&A, which method is preferred for maintenance? Total intravenous anesthesia, inhalation, or both? So a total intravenous anesthetic with propofol 1% infusion with around 200 to 400 microgram per kg per minute is preferred. If possible, if you have it, TCI pump can also be used. We find that giving TIVA with oxygen and controlled ventilation with atracurium is the best method for foreign body removal. If required, if experienced, dexmedetomidine 0.5 to 1 microgram per kg IV can also be used along with ketamine. So this is TIVA with the target controlled infusion pump based on Kataria or PEDFuser model. So between ages of 1 to 16, ages of 3 to 16, there are two different formulas. These all are plasma site concentration of propofol based formulas. If you have Elevate, which is effect site concentration prediction model, that can also be used. If you don't have a TCI pump and you don't want to give intermittent boluses of propofol or ketamine, which is not preferred, you can use this formula for McFarlane propofol infusion scheme for 3 to 11 years. It's when you give 2.5 mg per kg of propofol, then the first 15 minutes you keep it at 15 mg per kg per hour. Then next 15 minutes, reduce it to 13 mg per kg per hour, and so on as the procedure goes on. And if the child is less than 3 years, you can follow this STIR recommendation where you start with 12 mg per kg per hour. This is the bronchoscopy video taken in, this is just a little bit fastened. Yeah. So first when they go in, they have to check both the sides. Go to the normal side. So in this, you can see that there was a foreign body on the right side. So they've gone to the left bronchus. Now they're going and seeing the secondary bronchus. They've come out and they've seen that it's present in the right. So they go out. At this point of time, you'll have to ventilate through the side port. Once they put the instrument in and they're going distal to catch hold of the foreign body, please do not ventilate at this time. EtCO2 is not reliable, so you have to ventilate and look at the chest rise. So they have removed one foreign body. After the foreign body removal, always go back for a check bronchoscopy. You have to coordinate the ventilation with the position of the bronchoscope. So if you take distally, you have to give smaller breaths. So now you've noticed there is another piece in the left. It's probably the main piece which broke and went into the left. So they've removed the second foreign body as well. After that, they go in for a third check. In case at this point of time, there is hypoxia, you have to ventilate by withdrawing the scope till the trachea. If still hypoxia is less than 80% and it's not improving, you will have to ask them to come out with the bronchoscope, insert an ET tube and oxygenate. So concerns with an organic foreign body as it causes inflammation in granulation tissue, and this can cause bleeding and trigger bronchospasm. They can fragment and dislodge into the smaller airways, and these can be hard to remove from the rigid bronch. So either they have to wait for it to try and suction it out, and if it's not possible, give high dose antibiotics, and patient could develop pneumonia. Pent-up secretions beyond the obstruction can be released suddenly. If it's a large foreign body blocking the main bronchus, it can come and soil the other lung. So at that point of time, you'll have severe desaturation. Suctioning should be done with moderate pressures to ensure that there is not much mucosal trauma and loss of oxygenation. So during retrieval, what we saw that the foreign body can be fragmented, or it could be snagged or dislodged into the larynx, causing complete airway obstruction. So if it's a tamarind seed or something, so in a small child, that can cause complete obstruction, and it is slippery, so it keeps falling off from the forceps. So what will happen if it's completely obstructing? You're not able to ventilate. There is bag is tight, and there's no chest rise. So you have to ask the surgeon to put the bronchoscope and push the foreign body into one of the bronchi, so that at least you'll be able to ventilate through the other side. Sometimes in a very bad situation that they're not able to push it and they're not able to remove it. At that point of time, emergency tracheostomy will be required, distal to that obstruction. So post-operatively, after the procedure is done, they remove the scope, and if the child is spontaneously breathing, support the airway until emergence with mask ventilation. If suppose you have given atracurium and they have removed it within 5 minutes, you can insert a supraglottic airway or an ET tube and wait for the reversal of neuromuscular blockade. And if there is a lot of trauma, airway edema, there's bleeding and a lot of CO2 retention, intubate the child and then support ventilation till you feel that you can extubate. Very rarely, child will require a tube for post-operative monitoring, and you'll have to send the child to PICU. So if the child is awakened and reversed and okay, you need to give nebulization with levosalbutamol and budecort. Dexamethasone 0.15 mg per kg TID for 2 days. And as a rule, do chest X-ray to rule out pneumothorax and airway perforation. Sore throat, which is very common, can be managed with analgesics like paracetamol and NSAIDs. So there is a dilemma between controlled ventilation and spontaneous ventilation. Each institute has its own preference. Controlled ventilation, we feel the advantages are good surgical working conditions and less inhalational agent concentration. So you'll have a faster recovery. And IPPV prevents the atelectasis, better oxygenation, and overcomes airway resistance. So disadvantages are that if ventilation is not possible, if the bronchoscope is out or partially inserted, so you will have desaturation. You'll have to coordinate with the surgeon to maintain good oxygenation. And because of your positive pressure, you might be overzealous, and to improve the oxygenation, you might be putting a lot of pressure on the bag. At that time, the foreign body also could move distally. And you have to give adequate titrated doses of IV drugs and relaxants. And because of this high barotrauma, you can have overdistension and alveolar rupture. There was a study done by Littman et al. Who said that no particular technique was found to be associated with greater incidence of adverse outcomes. They found that incidences of desaturation between controlled and spontaneous respiration, no significant difference was there. But they found that the laryngospasm episodes and the time duration for removal of the foreign body was shorter, and laryngospasm episodes were lower in controlled ventilation. So in spontaneous ventilation, if you think that you're not sure where is the foreign body, if it's probably in the larynx or probably near to the trachea, prefer a spontaneous ventilation till you're sure. Ventilation is ensured at all times. So even if the scope is into the right bronchus or into the left bronchus, around the scope at least there is entrainment of air, and child is spontaneously breathing. There's a faster reversal, and airway assessment can be done. You know whether there is edema or not when the child is breathing after the procedure. Disadvantages are maintaining the depth is difficult. Air dilution will occur. So how much of a high FI of inhalation you're giving, you might not be able to get the depth. That causes more coughing and bucking on the tube, and even surgeons will also be uncomfortable. You can cause airway rupture. And because of high concentrations, you'll have decreased cardiac output and arrhythmias can occur. So ventilation strategies, if you have a Thrive, transnasal humidified rapid insufflation ventilator exchange, you can use that, but this is only in children above 5 to 6 years. You can keep about 1 to 3 liters per kg of humidified oxygen. And at this point, the child is apneic. And you can use jet ventilators or as we have used ventilating bronchoscope. So the complications can be airway complications where laryngeal edema, injury, bleeding, type 1 negative pressure pulmonary edema, complete airway obstruction. So there can also be hypoxia, hypercarbia, aspiration of the gastric contents because the airway is open, and if pneumothorax can be present because of barotrauma or trauma from the bronchoscope itself. And if you're not able to completely retrieve remnants, and pneumonia can occur. Because of the hypoxia or hypercarbia, you can have arrhythmias and cardiac arrest. Neurologically, seizures also can occur. Complications will be dealt with by Dr. Bhavya. So to take away a message, a normal chest X-ray shouldn't rule out a foreign body. Better to have a negative bronchoscopy than a missing foreign body. Always be ready for emergency tracheostomy. And right now, there's no consensus on spontaneous controlled ventilation. So once you have removed a foreign body, never stop there. Always go back, check, don't miss a second foreign body. And try not to convert a non-obstructing foreign body into an obstructive one. And not all foreign bodies can be removed. So you'll have to, go for thoracotomy or bronchotomy. So MCQs. If the child develops complete airway obstruction in the emergency department, what should be done? So the answer is
Many have answered option D.
Yeah. So D, as the previous flow chart was put, basic life support for a choking child algorithm. So usually having a case coming to the OT with complete airway obstruction is rare. It should be dealt with in the ER. Topicalization of vocal cords with lignocaine during induction helps in
Many of them have answered A.
Yes, ma'am. A is the right answer. It reduces cough and cardiovascular response. Be careful that maximum dose is 4 mg per kg. So 4% lignocaine topical contains 40 mg per ml. So calculate accordingly.
Akshara, I'm sorry to interrupt. This after topicalization, suppose the foreign body is removed quickly, there is a chance of aspiration post removal till the effect of the lignocaine wears off.
Yes,
Okay, so we have to be careful and monitor the child for that much time. Go ahead.
yes. If the foreign body slips into the larynx during retrieval and causes complete airway obstruction, the immediate step is
And there are multiple answers. Majority have told A option, but D option has also been opted by 3-4 people.
I think if we have a bronchoscope ready, we should try to push it down to one bronchus. Option A should be first attempted. If that is still not possible and child is having cardiac effects and hypoxia, and then you can perform a cricothyroidotomy.
Again, I want to add that if you don't have a bronchoscope also, it's okay. You can just
The ET
intubate. Yeah.
Yes, with the ET tube
ETT,
also.
you can push it to the right
Sometimes
bronchus.
before they start the procedure and you have you're mask ventilating or you've started with inhalational or with IV propofol, you could suddenly have a tight bag and you have to suspect that a bronchial foreign body has come into the tracheal. So at that point, you will have to use your ET tube and try to navigate and push through. These are the references.
Ma'am, we have some queries from the chat box. So first is like, why both fentanyl and ketamine was used in your institution?
We give fentanyl because we want the cardiovascular response to reduce, and ketamine because we want IV sedation and hypnosis and bronchodilation. And since we're not giving any other pre-medication, this is what we go for.
Okay, ma'am. Then one more query. What is the mode of ventilation that can be used in foreign body bronchus retrieval?
We prefer a controlled ventilation in our institute, and we feel comfortable with having a rigid bronchoscope available. But spontaneous ventilation can also be done, but you'll have to uh, change your plan according to where is the foreign body, what type of foreign body, how long has it been acute or chronic, and how comfortable you are with maintaining depth with an inhalation.
Okay, ma'am. Another query. Is there a role of jet ventilation in foreign body retrieval?
Yes, jet ventilation can be used. In pediatrics, jet ventilation, we don't have experience with it, but it can be used.
Okay. Then role of flexible bronchoscope in fiber optic in foreign body removal.
So in ENT, there are a lot of criteria as to when we should approach with a flexible fiber optic or when we should go directly for a rigid bronchoscopy. It depends on the presentation, and it depends on what they're suspecting. If it's like a chronic history or pneumonia, or you're not sure, unsure of what it is, you can always go with a flexible fiber optic first as a check. But we should know that with that flexible fiber optic, you will not be able to retrieve a lot of foreign bodies. You might be able to diagnose suction, and very small foreign body or anything will come out with the suction. But if you're very sure that this is what the case where you suppose it's a pin or a coin or anything, there is no doubt about flexible. Go right ahead with rigid bronch. But instead of having two separate procedures, many prefer to go with a rigid bronch and then have a negative bronch.
Okay, ma'am.
Ma'am, this was one more question. What is mode of induction in laryngeal foreign body?
So in a laryngeal foreign body, it is better to maintain the child spontaneously and with inhalational induction with sevoflurane and oxygen at 100%.
You
And
may not
what
have
is
the time to induce in a laryngeal foreign body. You can just do even an awake laryngoscopy and just remove the foreign body if it is a laryngeal, because it is almost a near arrest kind of situation. So life-saving method is to just remove it awake, and if possible, give a very little sedation.
there is one more question. Jet ventilation or oscillation, when do we use it for what type of foreign body? Jet ventilation and oscillation.
Uh,
Akshara?
Uh, if it's a bronchial foreign body or a distal foreign body, I think it would be better to use apneic oxygenation with jet ventilator and not a more proximal or a large inorganic foreign
Yeah,
body.
that query has been raised, ma'am. What is the role of tubeless technique in foreign body removal?
yeah.
TIVA with tubeless is preferred, but it depends on the age of the child. All
There's a risk of entrapment of air
air,
because all
will
these techniques will push air inside, but expiration is not ensured. So we do not prefer those techniques for foreign body. And in our institute, though we have Thrive, so far we have not used it because of that fear, and we don't have a method of seeing the ETCO2 because it's not reliable even with Thrive. So we are waiting to have transcutaneous, CO2 monitor so that we may, try to use Thrive, but it is preferable not to, use these, and we are very comfortable using the side port for ventilating the child because, ventilation is as important as oxygenation or more important.
Okay, ma'am. Thanks. One more query was there, ma'am. Why can't we use LMA, and through that LMA we can put the fiber optic bronchoscope and visualize the foreign body?
See,
this
fiber optic is not at all an option for a foreign body. Okay, you cannot retrieve. You will simply be wasting time, and you will be, fiddling with airway and causing more edema and trauma. So you should just directly go with a rigid bronchoscope wherein you can both visualize as well as remove the foreign body as soon as you see it, so that you save time. Fiber optic is only when you don't know what it is, you're not at all sure and you're almost 90% sure it is not a foreign body, and it might be some other, some mucus plug or something. Only then you do fiber optic, and then if you realize it is a foreign body, again you have to do rigid. So there is no role for putting LMA. You can put for if you are doing fiber optic for any other reason, but not when you know it is a foreign body or a suspected foreign body also.
Okay, ma'am. One more query, ma'am. Why are we not using glycopyrrolate, even though we are handling airway and in pediatric patients?
Akshara?
As a routine, prophylactically giving glycopyrrolate or atropine is not helpful. It causes unnecessary tachycardia. If this is an adequately fasted child, uh, I don't think we should cause heart rate. And along with all the bronchoscopy and the stimulus, the heart rate will go above 180 to 200. So we don't require it.
Okay,
There
ma'am.
is one more question. Hemorrhage maneuver to be given irrespective of location of foreign body. Have you encountered any incidents of complication arise because of this maneuver?
So far, we haven't seen. We haven't seen anyone who has given Hemlich and then the child has been brought to our institute. So it is a something which bystanders do. So I haven't seen that kind of a situation in our hospital. Child coming after a Hemlich maneuver with some complication.
Ma'am, there is one more question. How much time will take for retrieval of foreign body from bronchus?
It depends on
Depends
the,
which.
yeah, depends on the foreign body where it is lodged. So the average time can be taken to be about 30 minutes to 45 minutes. And unless it's a very difficult foreign body location, which Dr. Bhagya will elaborate further about, usual peanuts which are lodged in the any of the bronchus, it shouldn't take more than 45 minutes to 1 hour. And again, it depends on the expertise of the surgeon. A more senior surgeon would do a faster job, and a junior might take longer. But that's the average, 40-45 minutes.
Is there any change in anesthesia management if the foreign body is a battery?
See, generally we don't get battery in the trachea.
Yes.
Okay, we get it only mainly the children. It's quite big and they cannot actually aspirate it. Very rare, and it's usually esophageal foreign body, not a bronchial foreign body. And in either case, it's a very urgent situation because it can cause chemical damage to the mucosa. It can cause a fistula, tracheoesophageal fistula, so it has to be removed immediately. The management is the same, except that it is a more urgent and emergent situation. And anti-edema measures have to be taken, and usually post-operatively the child may have to be ventilated till the edema comes down. Anything else? Can we move on to the next talk?
Yes, ma'am. All the queries were answered.
Thank you, Dr. Akshara. That was a wonderful presentation, and I hope everyone who heard her is more enlightened about how to manage foreign body. And now we are now going to move on to a very specific and special kind of situation. Our professor, Dr. Chandrakala KR, has put together some information for all of you. When a mentally retarded, or sorry, we shouldn't say mentally retarded actually, a child with intellectual disabilities, usually they are prone to, this kind of aspiration, because unknowingly they may, put things in their mouth without realizing what it is, and there is a chance of foreign body aspiration in such children. And when such children present to us, apart from the foreign body retrieval management which has been discussed so far, there are other aspects to it. which Dr. Chandrakala will enlighten us about. Now I hand over to Dr. Chandrakala. Dr. Chandrakala, ma'am?
Yeah, I'm sharing this. Start podcast. Good evening, everybody. I'm Dr. K.R. Chandrakala, Professor in Anesthesiology Department, Indira Gandhi Institute, Bangalore. So I want to give you some information about the anesthesia for intellectually disabled child. Now I am giving some case scenario where the patient has a 6-year-old child with 18 kgs with a Down syndrome. It has got intellectual disability with hypotonia, macroglossia, which operated VST. So he presents with a sudden onset of cough, wheeze after the peanut injection. SpO2 will be is 89 to 94 and improves with oxygen supplementation. So he clinical presentation is anxious, restless, drooling, and as inspiratory side, right-sided wheeze. Tachypnea and SpO2 is 95. Chest X-ray shows hyperinflated right lung with a mediastinal shift. That is the diagnosis for this foreign body right main bronchus. So my anesthetic concerns in this case is uncooperative child due to poor communicative skill, difficult airway, concern of post-cardiac repair status, risk of airway collapse during induction, shared airway, aspiration, and dislodgement of the foreign body. Pre-operative preparation, as my colleagues told, same oxygenation or sedative to prevent the obstruction, complete obstruction. Prepare the difficult airway cart because they are mostly associated with syndromes and difficult airways, and informed consent for all these things. Fasting duration should be increased where the gastric emptying time will be increased in these patients, like CP patients. Then intraoperative management will be as a standard monitoring, induction with propofol, fentanyl, dexamethasone 2 mg and hydrocortisone 0.1 mg per kg. Maintenance will be isoflurane with the intermittent propofol or TIVA or TCI. Cord sprayed with lignocaine spray, ventilated with side port with rigid bronchoscope, and FB successfully removed. So our key learning points are: maintain spontaneous ventilation until foreign body is visible to prevent migration, avoid relaxants until airway is secure, account for comorbidities in special child, post-op monitoring is essential. Avoid hyperextension in the view of atlanto-occipital joint instability. Now coming to the theory part of anesthetic challenges in ID children. So to say it is an ID that is intellectually disabled, intellectual function deficit, there should be functional deficit and significant limitations in adaptive functioning. Evidence of limitations became apparent during the development period of childhood or as adolescent. Coming to classification of ID, that is degree, it depends on the IQ, and it is divided in mild, moderate, severe, and profound. Then coming to causes of this disability, some genetic condition like Down syndrome, Klinefelter syndrome, congenital hypothyroidism, Williams syndrome, and CP. Maternal causes are maternal alcohol intake, infections like rubella, and perinatal insults, fetal hypoxia during labor, like very commonly seen in cerebral palsy. We in our institute we get to know see these cerebral palsy, Down syndrome with rubella syndrome. So these are very common causes for ID. Then the patients will present with to us for various anesthetic techniques for diagnostic and therapeutic and surgical also. CT scan, MRI, and electroconvulsive therapy, raised tube insertion also they'll come. Surgical, mainly they'll come for dental and oral, plastic surgery, surgery, and corrective surgeries for congenital malformation like cleft lip and palate. Our anesthetic techniques regarding the sedation and the general anesthesia are most commonly used. Sedation, lack of cooperation, impaired cognition and communication may result in difficulty in IV line and placement of monitors. Sedation is an effective and safe alternative for GA with comorbidities. Severe intellectually disabled patient will not cooperate for inhalational induction. Verbal communication is also not possible. So, coming to the sedation in this type of children, it reduces the anxiety in enabling cooperation. Commonly used sedatives are midazolam with the combination of propofol and ketamine. Fentanyl also can be used, and dexmedetomidine often requires higher doses. For this, we can use TCI pumps. And monitoring will be the BIS monitor to ensure the depth, and close monitoring of the airway is crucial. Oral ketamine is successfully used in severe ID patients. General anesthesia can be given to the small percentage with the large or extensive treatment like major surgeries. This GA is more beneficial effect than the sedation. As demonstrated by positive behavior at the subsequent recall appointments when compared to who were treated with the conscious sedation. So here the preoperative challenges are more in this intellectually disabled children. So because of this, again, communication and cooperation, and anesthesiologist will be depending upon the caregivers. History may unnoticed. Drawing of blood can be difficult, associated with congenital anomalies and medical problems. Patient with neuromuscular disorder will have repeated aspiration and chest infection. Assessment of airway for difficulty, and these are malnourished and dehydrated. They are associated with micrognathia, cervical instability, short neck, macroglossia, and palatal deformities. If there is no IV line or oral midazolam or oral ketamine can be given. Then if they are not cooperative, IM ketamine can also be given. If not possible, shift the patient with caregivers into the OT and induce with the inhalational agent. After the midazolam pre-medication, the constant monitoring, vital monitoring should be there, as they are very sensitive to the sedatives. The consent must be taken by parent or caretakers irrespective of age, increasing fasting time because their gastric emptying time will be more. Continued medication for like anti-epileptic, muscle relaxant for muscle spasticity like baclofen. Proper counseling of caretaker about the disability medical problems. So this is the the main concern is about pre-medication, and it is mandatory in these patients. It allows patients and families a serene hospitalization. It causes anxiolysis for easy separation, makes induction and IV access easy. It causes amnesia, decreased induction agent dose, anti-emetic, acts as an anti-emetic, vagolytic, decreases secretions, and it also causes analgesia. So how to give the pre-medication to these type of patients? It should be mixed with honey or sugar syrup or favorite juice of 1 teaspoon. Shift to the OT with the parents. Sedation score should be monitored. The non-pharmacological pre-medication like clown doctors, virtual reality modes, playing video of the child choice, video games. But these will not give adequate relief, and thus pharmacological pre-medication is necessary. These are some pre-medication regimes like midazolam per orally, ketamine, midazolam, and combinations also. It can be given. So restraint should be avoided as far as possible. If it is unavoidable, as a last resort, and trained staff should be available to control the situation. Parents' consent for this restraint should be taken. Intraoperative management, depending upon the type of the case, into pre-oxygenation can be challenging. IV access, if it is absent, the induce with inhalational agent, then start the IV line. If it is there, IV line is there, then IV induction can be done. Intraoperative monitoring of SpO2, it is CO2 ECG. If it is serious comorbidity is there, then invasive monitoring can be done. Calm and unhurried approach is very beneficial. Attention is given to drug interactions like psychostimulant, anticonvulsant, antipsychotic, antidepressants. Induction with a propofol with lignocaine or thiopentone with fentanyl can be done. Airway, in anticipated difficult airway, keep the difficult airway card and VDL and FOP. Depending on the comorbidities, there may be difficulty in mask ventilation, intubation, or laryngoscopy. Neuromuscular blockade and reversal should be avoided until the airway is secured because of unpredictable airway problems. Usually 8% sevoflurane and 2 micrograms per kg of fentanyl is sufficient to give optimal intubation condition. Extubation after reversal and return of protective reflexes. Shift to the recovery with the minimal monitoring. Regional anesthesia, it is very safe in this type of children. Caudal, epidural, lumbar, and combined spinal can be given. Only thing is the positioning may be difficult in CP patients or in a scoliosis type, depending upon the disease associated. And compartment syndrome can occur under regional anesthesia due to orthopedic procedure in lower limbs and inability to report the pain. So post-operative assessment and recovery, caregiver should be present in the recovery room for the assessment. Knowledge of expressions and reactions or discomfort of the patient can be great benefit in the assessment of pain and analgesic requirement. Delirium is very common complication because of fear and distress communication problems. Risk of dehydration, secondary infections are very common. Post-op analgesia, similar to the normal, pain appreciation is similar to the normal patient. Pain assessment is difficult. Unrelieved pain may cause tremendous discomfort, exacerbation of cognitive impairment, and affects all the areas of life like social, physical, emotional well-being. Various tools are available for measuring post-op pain in these patients with a mild to severe impairment. This is one of the scale that is revised FLAG scale. Here 5 categories are there: face, legs, and activity, cry, consolability. So we can score it from 0 to 10. More than 10 it indicates the pain. It has been identified as a reliable and valid measure. Risk of constipation in opioids, gastric bleed, and ulceration with anti-inflammatory is to be considered. IV paracetamol is the safest drug for mild to moderate pain. Regional blocks for severe pain like orthopedic surgery, some like osteotomy, hip arthrotomy and all. So IV tramadol of 1 to 2 milligram per kg and IV ketorolac can be given. Rectal diclofenac can also be given. Some special situations like cerebral palsies, muscular dystrophies, autistic disorder syndrome, we can handle. The anesthetic implication in palsies are motor dysfunction, GER, bulbar dysfunction, recurrent, because of this, recurrent aspiration, hyperreactive airways, and chronic lung disease. Intraoperative challenges will be IV excess, RSI due to GER. The muscular dystrophies development of malignant hyperthermia and is very common. And for this, we need to prepare the machine. That is by changing the soda lime, changing the circuit is very. Sometimes in corporates, we can change the machine only, or and TIVA is an anesthetic technique. So autistic disorder syndrome, here it is aggressive temper tantrums and psychiatric symptoms are there. GA is the most, general anesthesia is the most suitable technique with a good pre-medication like midazolam and for sometimes ketamine for severe forms. Now I will conclude this with treating ID patient is a challenge for anesthesiology due to lack of cooperation, communication, cognitive impairment. Proper counseling and education education of patients along with the caretakers and unhurried consideration approach with the presence of familiar person during anesthetic technique are the key elements of the successful anesthetic technique. It is always better to spend extra time with the parents and child before surgery to win the confidence of both and build the rapport. Plan A and Plan B should be there. If the Plan A fails, Plan B can be done. Some MCQs for the PGs. The most useful pre-medication for an intellectually disabled child. Is midazolam and oral serum.
Ma'am, they have started answering, ma'am.
Okay.
Yes, ma'am, they have answered option A.
Yes. Most of them have answered. ID patients with
More participation should be needed from the listener side. Whatever be the answer, I encourage everybody to kindly put an option in this chat box so that we can rectify all the mistakes also.
So second one is ID patients with CPR more prone to which of intra-op complication? Bradycardia, MH, acute renal failure, thyroid stone.
Majority has answered option A, ma'am.
Yeah, true. Then third one is due to Down syndrome, it is associated with important anesthetic concern. Atlantoaxial instability, pulmonary embolism, severe renal function, malignant hyperthermia.
All of them have answered option A, ma'am.
Okay, right. Which strategy is more important for safe perioperative management in intellectually disabled child? Avoid all sedative premedication, individualized plan with parental involvement, use of GA for all cases, avoid regional anesthesia always.
Many of them have answered A.
No, individualized plan with the parental involvement is important. Then post-operative pain management in ID child is best guided by verbal self-report scales, physiological parameters, and behavioral scales. No analgesia required due to high threshold. Routine opioid administration without monitoring.
And almost whoever have answered B.
Yes, true. These are my references. Thank you.
Any questions, or can we move on to our next speaker? I think we are also running short of time.
Yeah, ma'am, I think you can move on to the next speaker.
Yes. So our last speaker of the day is coming up with a very interesting presentation of a collection of different presentations of bronchoscopy which we have done in our institute. And Dr. Bhagya, who is an assistant professor in our department, has a very interesting slideshow. I hope you all will really, enlighten yourself with this. Over to Dr. Bhagya.
Thank you, ma'am. Am I audible?
Yes.
Is the slide seen, ma'am?
Yeah.
Can you widen the slides?
Yeah.
Yeah. Is it wide?
No,
Yes,
ma'am.
Bhagya, yeah, go ahead.
Yeah. Hello, everyone. I know everybody is completely exhausted by now with the management of foreign bodies. I just thought today I'll just describe a few of my experience with foreign body adverse events, especially few of the cases we managed in the span of 7 to 8 years. From what you have heard until now, and students who work here, everybody knows that once we successfully do a foreign body retrieval case, what is the experience we have? It's totally unexplainable. It gives us a lot of memories. Just ask truly a pediatric anesthetist, what is it for reality's sake? On a day-to-day basis, every foreign body case gives us a new shock. So here I have some 10 stories, which I just presented as each event that we witnessed. In these 7 to 8 years I have been with the cases. I call them as my bedtime stories because often these are the cases which give us either good memories or certain lessons. To begin with, I call this story a whistleblower story. There was this 12-year-old boy who had taken a whistle as a foreign body, and there was a naive surgeon who was a newcomer. They attempted to remove the foreign body and it got stuck in the vocal cords. And there are very few times as anesthesiologist we get a chance to be a hero there. So we just did a laryngoscopy, tried to retrieve it with McGill forceps. The story and the message here is complete airway obstruction is a real possibility that can happen. Often retrieving it directly is not the option. The best thing in majority of the cases you should do is ask the surgeon to push it back to one of the bronchus and then go ahead with the procedure again. This is the story 2. Here we had a 3-year-old boy who had taken stones as a foreign body. The stones were so multiple and so mixed with gravel that it was very difficult. Almost for 1 hour, gradually each one was picking. And by the time it took 1 to 1.5 hours, suddenly we witnessed that there is a desaturation. I was unable to mask ventilate. EtCO2 was not there. There was no chest expansion. We immediately intubated the child as well. But even after intubation, we were unable to adequately ventilate. So the first thing which we ran in our mind was pneumothorax. Absolutely, it was a pneumothorax. Immediately, a right ICD was inserted. Everything came back to normal. When multiple times the mucosal tear happens and the foreign body is like something which is so vast and spread apart, mucosal tears can cause pneumothorax. So one has to remember, this is the lesson here, that when such foreign bodies are there, please always keep an ICD kit ready. Since us in our hospital, it's a tertiary hospital, we often have most of the equipments well prepared in the OT. Our sisters and technicians are so good that we always have. But if there is any naive anesthesiologist who is going outside to do a foreign body case, always make sure the ICD kits are there somewhere, at least on a safe place. So even some foreign bodies like this open pin, these are also high chance of causing a tear on the mucosa. This was another 11-month-old child, which we recently did around 15 to 20 days back. The mother gave just history of one foreign body. She was so sure that definitely the child doesn't have a foreign body because I crushed it and gave it to him. Once we started removing the foreign body from the left main bronchus, we were so surprised. We removed almost 12 to 13 pieces gradually from the left main bronchus, secondary, tertiary. At one point, we got so tired. So together, both me and the surgeon made a choice that yes, we'll stop because it's almost more such a small pieces. Probably with a good chest physiotherapy, we can get it removed later. So unfortunately, completely the child recovered very well. So what lesson in this case was unwitnessed aspirations, inability to remove the aspirations. These are very important points for predictors. There is something called predictors for a post-operative course in any foreign bodies. So these perioperative events should not be ignored. Post-operatively, these children definitely need adequate monitoring in the ICU setups. This is my 4th story. This was a 2-year-old child. Very confidently, Chiku seed was the foreign body with the history. And as you all know, removing a Chiku seed is very difficult, especially in a 2-year-old child. The moment once somebody brings it very near to the trachea, it really causes complete obstruction. And in this child, we had a history of 10 days. So all we were sure was safely trying to remove the foreign body. And in that process, after 2 to 3 attempts, our surgeon was very successfully able to remove the foreign body. But the moment we removed the foreign body, there was complete pouring in of secretions, pus-like secretion, which entered into the oral cavity, which made us very difficult for ventilation further. And with laryngoscopy also, visualization was very difficult. So immediately we did with a good wide bore catheter suctioning and reinserted the rigid bronchoscope, again continued with suctioning and removed every infected secretion. Luckily, there was no other foreign bodies apart from this, but the pent-up secretions in a chronic foreign body is definitely an important message to be taken from this case. We all know hypoxia, desaturation is a very common kind of adverse event spoken every time. But the most important thing that matters is finding out the exact reason why hypoxia has happened at that moment. So this is a fifth story, a 10-month infant. They had taken a plastic bead as a foreign body. And the mother was very sure it was from some necklace. Why I wanted to tell this story was, even when we did a chest x-ray, when there was a CT done, everything was so inconclusive. The child had already visited 2 or 3 hospitals and came to us, this hospital, after 7 days with the sole complaint that the child has lost his voice. The only complaint and worry the mother had was the voice that was lost. It was the case which we had taken at 7 o'clock in the night. All of us were totally surprised. Immediately when the laryngoscopy was done, first there was a metal foreign body just below the vocal cords. Once when that metal ball was removed, immediately there were 2 more which were stacked just below and further 1 more in the right main bronchus. Fortunately, all the 3 were safely removed, and I still consider this case as an absolute luck, because in a 10-month-old baby, having 3 beads stacked in the trachea in a specific position in which the air can enter can only be luck. This case, our surgeon has also presented and published also. You can see the X-ray reports, CT reports, and the beads also, which really baffled us in the middle of the night. So this was a story, 6th story, 3-year-old boy. Another case, most of these cases we take up in middle of the night. I still don't know why parents bring them at the night after most of the events happen. This foreign body, when they took up, they saw foreign body in the right bronchus, caught hold of it, brought it till the trachea, and when they removed, there was a half cotyledon of foreign body. The surgeon was very sure they had removed the foreign body. But once the foreign body was removed, there was immediate desaturation, difficult to ventilate. The child was intubated, but even after intubation, air entry was definitely reduced on both lungs. This surprised both the surgeons as well as the anesthesiologist. But as you can see, in most of such situations in the middle of the night, when such events happen, often conflicts arise between the surgeon and the anesthesiologist. The surgeons were very sure that they have removed the foreign body, and whatever the event that has happened is probably because of anesthesia management. And the child was kept in the PICU for almost 24 hours. And we all decided together that we'll take up it after 2 days. So we went for a re-exploration. You won't believe the foreign body half cotyledon, another half was left back in the right bronchus. There was another piece in the left bronchus as well. So these kind of situations can arrive, and sometimes the majority of the times conflicts arise between. So it is very important in such situations, have a proper post-procedural plan. You don't know what is going, all you know is just the child is not stable. None of us are sure how many foreign bodies are there. The primary important thing is stabilizing the child. With the foreign body, with an ET tube, stabilization takes the primary concern. There are many guidelines given as to which of the children you have to send with the ET tube to the PICU and take up for re-explorations. This is my 7th story. A 15-year-old boy. He came with foreign body-like symptoms. So almost 3 times we took up the child for bronchoscopy. Every time it was negative. Chest X-ray, CT, everything was inconclusive. But there was this strong suspicion both among the surgeons and us that it should be a foreign body. And it was a 15-year-old boy. So after many, many days, at last we decided to take up the child for elective thoracotomy. Child underwent a right lower lobectomy. And you won't believe, once we dissected that removed portion, there was a red drawing pin attached to the lobe. So these are some of the cases where it's not like we can remove all the foreign bodies. These are called as unusual foreign bodies. They are always challenging. They're never straightforward. But whenever you have a strong suspicion, the clinical symptoms are aligning with, never give up. There is one this for article by St. John's surgeons. It's also a very good article on unusual foreign bodies. And yes, our institute has also given a good 6-year experience of 301 cases done in our institute, exclusively describing major unusual foreign bodies we have removed over the many, many years. A good article. This is my 9th story. A 4-year-old boy with peanut in the right bronchus. The foreign body was so much swollen that it was infected, and unfortunately in the night they were unable to retrieve. One more attempt was given in the next day as well, but it was so difficult that we had to end up discussing with the parents, caretakers, team members, do a tracheotomy and remove it ultimately. Luckily, the child recovered very well. We even closed the tracheostomy suture on procedure the day itself. But the lesson from this is, such a scenario can arise. Like I said, we can't remove all foreign bodies. We might end up in thoracotomies. Sometimes we end up in tracheotomies. These are all possibilities. This was a nice, cute story. There was a birthday boy who was celebrating at the middle of the night, and along with the cake he cut, he swallowed one of the rings which he had taken. And they brought this child in the middle of the night, and our junior students, everybody thought it is in the trachea, and they were like, we have to take it up immediately. And clinically, the child was fully sound. All the surgery side said was because it's an open ring, the baby is able to breathe, and that's the reason why it is very asymptomatic. But luckily, the senior surgeons took a call, not just AP X-ray, we'll take a lateral X-ray. When we looked at it, and unfortunately for us, the child had eaten cake. It was no NPO itself. So once the lateral X-ray was done, we were very sure it was in the esophagus, and we waited for the adequate NPO and removed it by upper GI endoscopy the next day. This is last stories. Not all stories are kind of blessings and good time stories. This has been a story. Two of my friends, it's become kind of nightmares. They had a case of around 10-month baby where they tried to remove the foreign body 5 attempts, and they removed the foreign body as well. But immediately after the removal, like any other bad event, there was difficult to mask ventilate, difficult to intubate, severe edema. You have to understand this 10-month, 1-year-old children, they have a very small bronchus, and the commercially available bronchoscopes are also exactly fitting. So any edema can immediately reduce the diameter of the tracheas. So once this happened, there was a hypoxic cardiac arrest. Somehow they managed to intubate the child after some time. But the thing was, once they shifted to the PICU, there was a completely different picture. The child was having the chest X-ray, the ventilatory parameters, everything looked like there was some asthma, acute asthma, or a hyperreactive. Even the intensivist was surprised how this kind of picture. And when the only thing we all could come up was probably this was a popcorn which was spiced with paprika. See, we never know how a foreign body can behave. Just any foreign body can surprise us and give us lessons for life. This was such foreign body. Why I wanted to tell you this case was, recently in 2025, they have made a statistics specifically on whether there is any change in the past 31 years regarding the incidence of foreign body intake, mortalities, and among the various nations that are available. What they found was very sad. what they found was the incidence of foreign body because of education and various other things has reduced. But the mortality and adverse events in foreign body has increased by 7% in this 31 years. Probably somewhere bringing the child inside the OT, management inside the OT, this is kind of exclusively towards us targeting. So that needs a little more change. And these are two interesting cases in the literature I looked through. This was just a 15-year-old boy who had taken a pen cap. Why I put the slide was, here the surgeons used almost every other technique to remove the foreign body. Initially, there was a foreign body that was lodged pen cap in the left upper lobe. Initially, they used a forceps, tried to remove the granulation, thorough suction. Then they used holmium laser to remove the granulation, and then shifted back to ICU, took the child again second time. This time they used cryoprobe. And once the cryoprobe was used, they saw the bronchial opening, but the bronchial opening was not adequate enough for the instrument to pass through. So they used a balloon dilatation, dilated the bronchus, used the basket and removed. I think this is only one case in the literature where literally every possible option right now available has been used to retrieve it and avoid an open procedure. This is another sad story, but a happy ending of a child, 2 years. It's in the literature, recent 2024 article where pneumonia was considered as a diagnosis by most of the people in the pediatric surgery, pediatric medicine. The child almost ended up in pneumomediastinum, almost going to ECMO, and somehow survived because there was one pulmonologist who wanted to do just a suctioning because they were unable to maintain the ventilatory parameters. This is also a nice case report. I saw one of the person recently asked whether spontaneous ventilation is good or a controlled ventilation good for foreign bodies. Literature has said with respect to adverse events that are happening, neither of them have a upper hold. So just to brief all the perioperative events that I've covered as stories throughout this presentation, these are, you can roughly easily remember as ABCN, airway, breathing, circulation, neurology, complications, available in textbooks, you can easily through. Just ending my slides with a few takeaway messages. What I want everybody to remember is this is a preventable accidental mortality and morbidity case. So our preparation, the more we learn, the more we understand this case, definitely makes a change in our management of pediatric anesthesia. Always anticipate, and this definitely comes with experience. Have a plan always, and never underestimate communicating with your colleagues. And every foreign body case, no matter how many times you have done, how many years you have done, never follows a rule book. They might give you lessons, they might guide you, but every case you do, they always give lessons, something you can give for the future. And definitely, I want to take this opportunity to thank all my pediatric surgeons, because I think this is one case where mutually we learn from each other. And definitely, I want to thank them all. Thank you all.
Dr. Madhuri and Dr.
Thank you,
Can we
ma'am.
take any questions, or
Yeah, just look if there are any questions, Dr. Pooja. Any questions left in the chat box?
Yes, ma'am. One question they have
Yes,
asked
ma'am.
is,
Yes. Ask the question.
Yeah, go ahead.
And there is one question.
Yeah, Pooja, go ahead.
ma'am, in case of foreign body cricopharynx, whether we need to intubate or not, what will be the management? That was one query that is raised.
Yeah. Foreign body cricopharynx, cricopharynx, yes. See, majority, 99% of the time, we do direct laryngoscopy and remove the foreign body. It will not cause so many intraoperative adverse events. So often it will be just a coin, but the problem arises if the foreign body is like battery or a sharp foreign body. Certain kind of injury is anticipated. So in that scenarios, maybe for airway securing, depending on how the child behaved perioperatively, we take that call. Majority of the cases to intubate, not to intubate, to put them on venti or no venti, the periop course gives the idea.
Okay, ma'am. And one more question, ma'am.
Hmm.
Full stomach with foreign body in trachea or battery in esophagus is a headache. Any comments, especially in less than 3 years of age?
But definitely, it's a headache. I don't deny this. And unfortunately, we have also seen many battery children ending up with tracheoesophageal fistulas coming very late. And yes, this is definitely a challenging scenario and sad scenario sometimes.
Okay, ma'am. Thank you so much, ma'am.
Thank you. Thanks.
So there are no more questions.
No, ma'am. Everything has been finished.
So I want to thank Madhvi ma'am for that excellent presentation by her team and the excellent coordination and so many innovative ideas in the entire presentation.
Thank you
I
so
just
much.
thought I could listen to Dr. Bhagya's bedtime stories forever and ever and ever. Very, very interesting.
Yes, an
And
excellent
the
presentation.
presentations by the fellows were very effective. And Dr. Chandrakala ma'am's presentation on mentally retarded child was also very useful.
Thank you, madam.
Yeah.
Thank you so much, ma'am. I hope we have made a difference to the learning about FB bronchus to whoever has listened in. And thank you again for giving us this opportunity to share our experiences and
Yeah.
knowledge, whatever little we could
Yeah.
share.
Are there any questions, Dr. Pooja? Anybody wants to ask questions from the audience? Has anybody raised their hands? Just check.
No, ma'am. Actually, we have
There are all
answered everybody.
compliments. Yeah, there are
Yes, ma'am.
compliments.
Compliments.
Just one question, ma'am, I mean, anybody to the fellows. Like, are you all making use of lung ultrasound also for these cases of foreign body bronchus? Is there any role of lung ultrasound?
Bhagya?
Ma'am. Ma'am, lung ultrasonography per se has very minimal use in foreign body bronchus, ma'am. And
Okay.
all we can detect is reduced air entry and the movement of the pleura less on that side, but it will not confirmatorily say it is foreign body. But yes, it will be. There is only one case report which I recently looked through that in an adult they had used for foreign body retrieval, but in pediatrics it is still conflict, ma'am. Maybe we'll get some results in future days.
Yeah, maybe you
Well,
can look for lung atelectasis and
Yeah,
pneumothorax,
yeah, sure, ma'am,
those
sure.
kind of things which you were talking about, isn't it? You
Yes,
will,
ma'am, yes.
Not for
yeah,
diagnosis per se. Yeah.
yeah.
Diagnosis, ma'am, basically what happens in the trachea when the posterior tracheal rings are deficient posteriorly, the cartilaginous part. So it's a very difficult to, the real obstructive pattern on ultrasound because the three-dimensional picture may not be able to you get from that. And even if you try to assess the anterior posterior side, I think it's very difficult. The only part is if you want to use ultrasound here is I think when it migrates to the distal end of the smaller bronchi, there can you can see the exact location. Maybe radiologically you can supplement it with ultrasound, and I think that's the only thing at the moment which can come. Otherwise, in the class, I think whatever the scenarios were there, which I think covered by the worst scenarios covered by Dr. Bhagia, these are the things. And the learning curves to these type of management is not so simple. If you think that I have done 10 years in airway management or 20 years, 30 years, you can still face the music one day in encountering such cases. So, because even the foreign body, the type of foreign body, sometimes we may not have seen that foreign body, may not be reported in the literature when it comes suddenly, especially from the rural areas, if it comes suddenly you may not, we have to develop the plan intraoperatively. Intraoperatively means rather after doing the laryngoscopy or when you are exploring the airway. So those are very difficult situations to handle. And I think those are the things which we should be reporting. We should be making a literature for the future generations, clinicians to see how to manage such bodies, foreign bodies. So I think those explanations of the different scenarios is a eye opener for many, especially the postgraduates, because whatever has been given in the books is just for the sake of the knowledge that removing of the foreign body with the said protocol is very, very essential. Stick to the basics. Don't try to be adventurous in removing the foreign body. If you follow the basic steps, I think 95 to 99% you are always safe. So for 1%, the seniors like Dr. Madhavi are always there. So and Dr. Bhagya, Dr. Chandrakala are always there. Rest, I think 95 to 99%, the protocols will give you the good results in such cases.
Absolutely.
Yeah, that's the reason. And I think the first thing you mentioned in the beginning, the awareness, I think it's not just awareness, it's the multifactorial, which you also mentioned that going to the other centers. Now, with many of the
Yes.
smaller centers also having the gadgets for difficult airway management, getting the knowledge of difficult airway. So people in the practice, they do manage at that thing because nowadays, everybody wants to go to the workshop of airway to learn these type of things, and they become very confident.
It's a
That's
good,
how the real knowledge
yeah,
is helping it and the reducing the burden on totally
very,
focused
yes, yes.
child health institutes like yours. I think this is the takeaway message from the entire class that never underestimate any foreign body.
True.
That's the reason. So, ma'am, before proceeding forwards, let us felicitate the people who have done hard work today. My screen visible, madam?
Not yet, sir.
Yeah, Madhvi, madam, first
Yes.
of all, you taking the initiative,
Thank you so much, sir.
and it's a good one, and the class will remain etched in the this one on the of many people who attended it today, and will remain also as a recorded class in the YouTube at ISA NHQ. So thank you, madam, for being the class leader for this particular
Thank you, sir.
class.
Thank you very much.
And Chandrakala, ma'am, yourself and Dr. Bhagya, you have prepared the students very well, and you have managed the. Your slides were also very good, as already I think described by Dr. Madhuri. So we are thankful for your this one class particular presentation for today's class, ma'am.
Thank you, sir.
And Lakshmi, as well as Akshara, you were right to the points. I think the real fellows are being in a shape. They are going to get some experience, and they will definitely become a very good pediatric anesthesiologist in another 2 3 years. And we are best wishes to you, and congratulations for presenting such a beautiful class today. Thank to both of you also.
Thank you, sir.
And Pooja, as well as Rajni, you both are our screen coordinators, and it's not just the screen coordinators, it gives you a confidence of being present on the national scene. That's how our youth should go forward. Now, today you have presented as a screen coordinators. Tomorrow you will be doing something at the national level also. Thank you, our screen coordinators. And Dr. Madhuri, Dr.
Thank you,
Nishan,
sir.
they are always there with me in the classes, helping in coordinating such events in a precise manner, in a technically correct manner. And that's how these classes should be. And one thing I want to say that we are no less than anybody in the world now. If you ask, no society in the world has got so many classes, a dictionary or a depository or whatever is a collection of so many classes which are available free on cost, no charges for that, and you can go to any class anytime for your examination for supplementation of your knowledge. But the books are your best friends, still the best friends, but these classes are a good supplement to your knowledge. I think we are the global leaders now in these classes, and it's very difficult for us for anybody of us to beat now in these classes with more of the innovations coming in the coming years also. Somebody want to say, ask something, I think, raised hand also.
Chandrakala ma'am have raised a hand, sir.
No, no, no. Just it is by mistake I did that.
Okay. No, anybody can ask the things if you have asked to ask any question. But I think it all together, it was a good experience, ma'am. And
Thank you, sir.
after the class, you can see this class recording again on the YouTube at ISNHQ.
Thank you so
May I
much.
just add a little bit, sir?
Mane, I'm answering that because we have developed a Google form also, will be circulated throughout the country where anybody can fill the Google form and can ask for the class slots. Or otherwise, you can always mail me on secretary@gmail.com or send a direct message to me on my personal number. And for the Google form, it will be filled by anybody, and the slots we will be giving according to the availability. So the aim is to cover every medical college of the country. They should be on the national scene without any bias, without anything, no popularity. For us, all medical colleges are equal, whether these are the topmost colleges or just a new one, private or a government medical college. So opportunities will be given to every nook and corner of the country. So that this Google form will be circulated very soon, maybe in a day or two, because there are certain things which we wanted to add in that. So that's what we will be doing. And I think, ma'am, Madhavi, madam, your closing remarks before we close this class.
Again, I would like to thank you, sir, Dr. Bajwa and Dr. Madhuri, for considering us for this class. And I thank all my colleagues who did an excellent job in a short time. They put together very nice slides and presented very confidently. Especially the juniors' confidence has to be really appreciated. And sometimes I feel they do better than us as seniors while presenting, and I wish them all the best. And last but not the least, if there's anybody who is listening, please remember that when a foreign body bronchus comes, apart from doing everything, please do not hesitate to call for help. There is no ego in asking. Even if I get a bronchoscopy case today, I feel I'm not very sure, I don't mind calling Dr. Chandrakala or Dr. Bhagya or even Dr. Prabha or Akshara to help me, because you need sometimes, two minds and four sets of hands and four eyes, when you're doing certain complicated, it can become complicated anytime. So on that note, I would like to say thank you again to everyone for listening, all the PGs who were keen to listen at this hour to gain knowledge. Even we would like to thank all of them also. Thank you.
Thank you,
And
ma'am.
good night. Good night. Yeah.
And it's quite late now. I think everybody
Yeah.
is feeling hungry also. Yeah.
Yeah.
So from ISA National Headquarters, thanks to everyone for joining. And next, I think we will be meeting on Monday for the next class. Till then, it's a good night, goodbye. And we always
Thank you,
end by
Dr. Bajwa. Thank you very much, Dr.
thank you, sir.
Bajwa. I'm Dr. Reddy. I'm living in US, but I'm not practicing. I'm 80 years old. So 10 years back, I stopped working. I was in Kurnool Medical College and Mehboob Nagar also. And I'm very much, impressed by this webinars. It's very well conducted, very well organized by you people. It's very
Thank you,
nice.
sir. Thank you. So nice. So
Yeah,
nice to have a foreign faculty now. We will call you foreign
yeah.
faculty, foreign
Today's
senior
highlight
faculty.
is today's highlight is that bedtime stories. Actually, every foreign body bronchus is a nightmare for anesthesiologist. Actually, it's not that an easy job. I would have done many cases at SVS Medical College, Mehboob Nagar, as well as at Kurnool Medical College, Kurnool. But it's very. It is, if it is in the records, I can send to some of my colleagues also. It's very interesting. One of my colleague and one of my student who is a cardiac anesthetist from Kurnool, Dr. Kondareddy, I informed him today and he participated. He's doing a pediatric case now, 1-year-old child. Still, he watched this and he sent several questions also.
Yeah, I
And
saw
he
that.
has done
I
plenty.
saw that also.
Yeah, very interesting. Very interesting.
Yeah, so
Thank
that's
you,
nice,
Dr.
sir.
Bajwa.
Thank you,
Very
sir. I
nice,
think we
actually.
have to thank all our faculty from
Yeah,
different medical
yeah.
colleges who are doing this wonderful job. At least I think it's a
And
very philanthropic for all the PGs to
yeah,
learn from these classes, sir. Thank
it's
you,
very
sir.
well
Thank you for
educative,
joining.
eye-opening. Thank you very much.
Thank you, sir.
And
So
good night for you because it's too late for you.
yeah, no.
Yeah,
So I
it is
think
daytime
that's
for me.
we are ending on a very good note, sir, with your
And
participation here, and it's a very
the
heartwarming.
timing is also very good. Even I finish my morning walk, and then start this. It will be 8 a.m. here for me and 6:30 p.m. for you.
It's 8:30 p.m. for sir. 8:45 now.
You started at 6:30.
Yeah. We started at
6:30. Yeah.
6:30, sir. Yeah. Thank you, sir. Thank you for that.
Thank you.
And
Thanks,
yeah,
everybody.
Thank
yeah.
you so much.
Thank you, everyone. And now we end by saying, "Long live ISA."